be talking about, and we're going to be recording it we'll put it on the Berman Institute website as we do for all the Ethics for Lunch. Today's session is going to be dealing with the diagnosis of death by neurologic criteria. Sometimes that can pose challenges. There can be complicated cases where it's difficult to interpret some of the results, or there are other factors involved in making it challenging. So we're going to walk through a case, and we have a distinguished panel to talk about the case and the issues that might be involved. Suzanne, if you could advance the slide, and I'll have each of the panelists introduce themselves. So we'll go to the next slide, and we'll start with April Sharp.
Hi, I'm April Sharp. I'm a fellow in pediatric neurology, focusing in neurocritical care.
We'll go back to the last slide, and Adam Shabi.
Hi, I'm Adam Shabi. I'm attending anesthesiologist and neurointensivist. I'm also one of the medical directors of our determination of death by neurological criteria support team here at Johns Hopkins.
Renita Somerville.
Hi, I'm Renita. I am a social worker here at Hopkins in the neurocritical care unit.
Anna Noguchi.
Hello, my name is Anna. I am the coordinator for organ donation, and I will be speaking to you from a bedside nursing perspective, and I was a MICU nurse for 5 years.
Reverend John Panala.
I'm John Panala. I work as the Family Advocate Program Coordinator and the chaplain for the Department of Surgery.
Great, thank you all. So we'll hear from each of them, and I'm going to walk you through the case. So this is a BD, a 22-year-old, previously healthy young man, admitted to the cardiac care unit. He had a sudden unexplained cardiac arrest. He was running out in the community, found down by a bystander, a stranger, who initiated CPR, called EMS. So emergency medical services arrived. They also performed CPR for 30 minutes and were able to restore spontaneous circulation. He was then transferred to the hospital, admitted to the CCU for post-arrest care. We'll go back to the previous slide. He had a Glasgow Coma Scale of 3 on arrival. We'll talk a little bit about what that means. We'll go to the next one. His neurologic exam, he had small, sluggishly reactive pupils, weak corneal reflexes, no cough or gag reflexes. He had no spontaneous movement and no reaction to noxious stimuli. Over the next 24 hours of the hospitalization, despite being medically stabilized, he showed no improvement in his neurologic exam. Next slide. And then 48 hours into the hospitalization, his pupils were now fixed and dilated. He no longer had corneal reflexes. Imaging was obtained. He had serial head CT scans, found to have progressive global anoxic injury, which showed diffuse edema and bilateral uncal herniation. Based on these findings, it was made a decision to do an evaluation for death by neurologic criteria, otherwise known as brain death. And that requires 2 clinical examinations where there is an absence of any brain function, and there are criteria that we'll talk about to establish that. And those 2 exams have to be separated by at least 6 hours. So the initial exam was consistent with brain death, and they knew they needed to do a second exam that was performed 6 hours later. And during that, he had a spontaneous and stimulus-induced extension and pronation of his arms. It was thought that this movement was most likely a spinal reflex, but given the movement, it was recommended that additional testing, ancillary testing, be performed. And then the rest of the exam, apart from that, what was interpreted as a reflex, the rest of the exam did not show any neurologic function, including a apnea test. So he did have a cerebral perfusion scan that did not show any brain perfusion. and therefore it could be concluded that determination of death was met by neurologic criteria. However, the patient's mother, BD's mother, had been with him in the CCU since he arrived in the hospital. She was obviously shocked and devastated to learn what had happened, was appropriately very emotional when the team told her that he would be evaluated for brain death. She was present for both exams. And for the first exam, she sat at the bedside holding his hand and praying for his recovery. And during the second exam, she was the one that actually noticed the movements in his arm during that brain death exam. She felt that the movements were a sign that his brain was recovering and that it meant he could not be brain dead. The team, however, explained that the movement was likely a reflex and that it was not coming from the brain. She responded, I understand why you think that, but I know that it means he'll get better. When I press his hand, he moves. That's his way of saying he's going to be okay. He would never have given up on me, and I won't give up on him. So after the termination of death, after that second exam, she refused to acknowledge his death and requested that he remain on his current therapies, including the mechanical ventilation, indefinitely to allow him time to recover. So that's our case and all the challenges it presents. I'm going to turn it over to April to talk about how she would approach this case.
Thank you, Mark. So first I wanted to review in a little more detail the determination of brain death and what that is. So death by neurologic criteria, or brain death, is defined as the absence of neurologic function with a known irreversible cause of coma. This evaluation requires, is a clinical diagnosis, and it requires 2 clinical exams that are separated by at least 6 hours in adults and longer in children. And there are different parts of the exam to establish coma, absence of brainstem reflexes, absence of sensory and motor responses that are coming from the brain, and the presence of apnea. And so it's an exam that is done by a standardized protocol that is agreed upon at Hopkins and nationally, so that the brain death determination is clear and straightforward and can be agreed upon. The first exam establishes the absence of neurologic function. The second exam is confirmatory and establishes that this is an irreversible finding or determination. If there are any concerns about either the exam findings, as in this case, or the validity of the exam for any reason, then ancillary testing can be used to support the clinical diagnosis. Importantly, it is only supportive, and ancillary testing, like used in this case, does not substitute for any of the clinical exams. This remains a clinical determination. Spinal reflexes are one of the common complicating factors in brain death determination. These are reflexes that where the nerves and signals only go through the spinal cord, they don't go through the brain. They can be spontaneous, they can be induced by stimulus, like in this case when the hand is pressed. And they often show up a few days to a week or so after the brain injury, which is in the time period that we are often doing brain death evaluation. And so it wouldn't be uncommon for them to show up in the period of time when, or in the intervals between the exams, like in this case. And they can be very complex movements and very confusing for families because they're hearing that their loved one has no neurologic function, but they're seeing movement and they're seeing things that are happening with the patient. So in all cases of brain death, my approach is to be open and straightforward with the family early on. Often initially, all we can say is that they're explaining the injury and why we are concerned about a certain injury. It's often a severe brain injury. And then as we get more information with more time, if we are not seeing improvements or we're seeing actually worsening of the neurologic function, letting the family know how things are progressing and what we're worried about. It's important not to introduce the idea of brain death too early because things can really change, especially in that first 24 hours or as medications wear off or other situations change. But once I have a sense that we're going to be doing brain death evaluation, I think it's important for the team to share that and to begin talking about what that will look like and when we will do so. I think it's really important to use very plain, straightforward language when talking about the idea of brain death. It's conceptually difficult for those in the medical field and certainly for families who are in this usually unexpected situation. They're grieving what has already happened and very stressed about what comes next. So I often say something like, we're looking for the presence of neurologic function. And if we don't see any evidence of, or actually let's say brain function, the presence of brain function, if we don't see any evidence of brain function, then that will mean your loved one has died. I think the language of brain death can sometimes be very confusing to families, that, okay, the brain is dead, but the body is still alive. So as long as the body is alive, then my family member is alive. Whereas we want to convey that death by neurologic criteria or brain death really means death. And I think especially in this case, once the determination has been made, switching to language of talking about the body and talking about organs as opposed to life. So what I will say is, because of the exam, there is no evidence of brain function and your loved one has died. The machines that you see in the room are keeping the heart pumping, keeping the heart squeezing, keeping the lungs opening and closing. And they would not do so without those machines. Or when we turn those machines off, they will no longer be doing those functions. As opposed to talking about, oh, the heart's still alive, the body is alive. When we take them away, the body will die, things like that. And I find that in most cases, having that open, straightforward approach helps families understand what is coming during the evaluation and what is coming afterwards. When it's still difficult for families to either understand or to accept what has happened, the next portion is really all about listening and understanding who they are, where they're coming from, their values, beliefs, and working together with them to go through the next steps. So I think I will stop there and turn it over to Dr. Shavi.
So thanks, Dr. Sharp, for that. I look at this case and I see a lot of things that are very familiar because this is a typical patient that we would see in our situation in the NCCU. And this is also a very common complication that we would see in brain death determination. One of the things that I find in this case to be particularly troublesome for families is the acuteness of it. This is a healthy person who all of a sudden essentially has a drop attack, for lack of a better term, goes into a cardiac arrest, essentially dies and is resuscitated to the point of an unknown neurologic injury. And all this happens extremely fast. And, that family member, maybe talked to the patient 30 minutes before this happened, a very healthy, robust person. And that shock of the acuteness of the situation really leads to a lot of trouble in this situation, mainly because of the shock to the patient, but also in the lack of time that the medical team has to interact with the family. And it really takes a certain amount of time to develop a trust relationship that can be strong enough and be able to develop those bonds with a family that allows you to have these conversations easily. That is extremely difficult in a situation like this, and I see that as extremely problematic. And so what this really can lead to, and we're talking to a family member in a situation like this and saying, you know what, sorry to tell you this, but I think your loved one has died, and not died in a way that most people think about as death, dying in a way that even a lot of medical professionals and doctors don't even truly grasp. And as a society, clearly this is a troublesome thing, even though we have agreed that we want to accept death by neurologic criteria as a valid mechanism of death. It's like it's all fun and games until it's actually happening to you, right? You can say that, but when you're the one sitting in that situation, it can be really challenging, especially with the acuteness of this. And so it leads to this disconnect of, we're telling you that your loved one might be dead, or that they are if the examination has already made that conclusion. And just like Dr. Sharp was saying, that they're looking at a patient who looks exactly like they did this morning, except they're sleeping and may have a breathing tube in their throat and are connected to some machines. So education about neurological death is really, really difficult in this situation for the reasons that we've all talked about, that people in general are not medically sophisticated in a way that allows them to understand this very complex neurologic problem. And like we were just saying a second ago too, a lot of physicians struggle with this and medical professionals struggle with this as well. So there's not any reason why we should expect that family members who are not medical professionals are going to grasp this easily. And so it takes an extra amount of care, a little bit more time to help try and build that bond relationship that you would have had if you had known this family for a few days, or if they progressed slowly to neurological decline, where you would have already had that trust relationship, and they might actually be more likely to believe what you're telling them. But here, this is so quick that they, even if they want to believe you instinctually, they may not be able to, because they don't have that trust relationship built with you at this point yet. So when that happens and you have that type of a complication, it can be really damaging for the relationship. I'm just going to talk about the physician-patient relationship here for a second. It can become quite damaging to that relationship, and also to the relationship that that family has with all of the medical staff on the team that is taking care of the patient. But because the physician is the one that has to do this determination, we'll focus on that for just a minute. And the physician is really responsible for the certification, not only the certification, but the diagnosis as well. And it has to be extremely clean and straightforward, because many people are watching this. It's not just the families, it's all the rest of the staff, it's society, it's everybody is watching what is happening here, because we are talking about death in a way that doesn't completely make sense to everybody in an instinctual way, right? And so a very high level of care, a very high level of respect has to occur here, because people are watching, and if there's anything that is not by the book, so to speak, and you're going down the checklist of yes, 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 I meet all these criteria, without the addition of judgment, it makes it a little bit easier for people that may be watching. And if there is anything that's out of place in any way, staff members, family members are going to have a little bit more distrust, especially people that may know something about this. And that has a way of bleeding out into society as a generalized, or at least a generalizable mistrust for this process that we're talking about. So really, a mechanism should be developed, and we use this mechanism here, and I'm a part of this mechanism for whenever a situation is complicated like this. I believe, and our team believes, that the responsibility of not only certifying but also diagnosing the death of a person shouldn't fall on one individual, especially an individual who is trying to build a trust relationship with a skeptical family, especially if judgment is needed. So if there is judgment needed in the diagnosis of this, that can lead to more damage occurring and more mistrust, not just in this situation, but in society in general. And so our mechanism is to help relieve the burden of judgment for somebody's death, right? Being able to have it be as clear cut as possible, but if that's not possible, having additional help be available to come and assist in the judgment that's needed to say, well, this is a complicated situation. It doesn't fall exactly in line with death by neurological criteria, checking all the boxes, very clean and simple. Yes, the person's dead, yes, versus no, they're not. So that we actually have a little bit of groupthink involved, and that it can be elevated beyond one individual. And one individual is now being looked at, where the situation is being looked at and assistance is being given by committee, such that a committee can weigh in on this. And it helps to elevate the situation a little bit beyond just what would be considered a normal diagnosis. And it gives some backing for the individual who's responsible for it, which we believe can also lead to a little bit of increased trust, because it's not just a physician who may be mistrusted by the family saying, yes, this person is dead. We now have somebody beyond that, and a group of people beyond that, a group of experts, a second opinion, a third opinion, sometimes even a fourth opinion about what's happening here to help restore that trust situation. And that can be really, really a powerful thing to help with when trust is broken down. Now, I think I might be running out of time here, but I did want to highlight that even in a situation like this, there has to be a way forward. You have to be able to know, well, what should we do next? And if the family is still resistant, even after second and third opinion sort of a thing, which would happen with our team, how do you actually move forward in the intensivist situation or in the intensive care? Because being in limbo and not being able to progress forward is actually, in many people's minds, a fate worse than death if you really have no place to go. And so there has to be a way to move forward. And we could have a whole nother ethics for lunch about how do you actually move forward and what is the mechanism for doing this. But it does require a lot of institutional backing and discussion with the family, where you would try to figure out, does the person need to be brought to a different facility, like for example, to go to New Jersey, which is a state that actually allows for this type of thing to occur. The state of Maryland doesn't necessarily allow for this, and you'd have to get the courts involved and have a judge think about it to help you out with this. Ethics committee, the legal department at Hopkins, everybody has to get involved, and you really need strong institutional backing. But the opportunity would have to be presented to them that they could actually bring their loved one who would be considered dead by neurological criteria here, possibly to a facility who would accept that they don't accept it and be able to continue with support of the body. And with that, I think I'll stop there.
Turn it to Renita to talk about sort of the family perspective and social work involvement in these challenging cases.
Yeah, thank you. So as a social worker, I see what further complicates or could further complicate the situation of distrust in the brain death diagnosis are some of the things that our community, our minority community may bring to the table with their patients. And some of that is based on in history. There's some historical premises why some of our minority community come to Johns Hopkins with distrust already for our providers. I've heard as a social worker some what could be considered urban legends and things that have been passed down from generation to generation from our community. And some of it's based on a few historical events. Minority community has dealt with the Tuskegee Institute experiment, where poor, illiterate minority people were enrolled in an experiment in Tuskegee, Alabama, where they were told they were going to be treated for their syphilis infections, when actually the care providers wanted to just see the natural progression of the illness. We've also dealt with the Henrietta Lacks experience that many of you are familiar with Johns Hopkins, where her cancer cells were taken without consent for research. There was also a compost study done in this community where they wanted to see just kind of how to treat lead paint poisoning among children in the community. And they dispersed compost in the yards of African-American families here without their consent as well. So the community sometimes come in already with this mistrust already being established based upon some of these historical events. And I've heard things from families such as, you know, Johns Hopkins is more interested in medical research than my care. Hopkins makes guinea pigs out of Black patients. I've had families tell me that growing up, they were told never walk by Hopkins at nighttime because you'd be kind of taken in for research. And some families really, really believe these stories. They hold on to them. And so when they come into the hospital and are faced with a complication like brain death, they already have this distrust built up. And so it makes it even more complicated for them to trust the physicians about something so difficult to understand, as Dr. Sharp and Dr. Shivey have indicated. And when they come in with this distrust and this disbelief, sometimes they may present as what providers perceive as the family being difficult, disagreeable, angry, or non-compliant. And then that in turn can make the families feel judged by the provider, stigmatized, and that leads to further distrust between the team members. And so these negative narratives and misconceptions are definitely barriers to the trusting relationship. And when we add on top of that, we're trying to tell them that their loved one has died. And as Dr. Shivey said, many of them have, you know, it's a sudden event and they've kind of just seen their loved one or talked to their loved one. It makes it very difficult for them to believe. And so as a social worker, my role is to help try to kind of regain that trust with the families, between the families and the providers. It's imperative to engage to regain that trust. So in addition to kind of providing the necessary education on what brain death looks like, the criteria, it's important to try to maybe identify with at least one family member that you're able to kind of maintain that trusting relationship with. It's very important to structure the family meetings in such a way that the communication is such that they are able to understand clearly, being mindful of sending clear messages. Sometimes our teams can send inconsistent messages, particularly if as Dr. Sharp said, I believe, where, you know, they're seeing what they perceive as signs of life, movement in the body. They're seeing monitors with heartbeat, and their perception is that patient is still alive. So being clear with those when they're seeing inconsistent signs as far as they're concerned. It's also important as a social worker to remind the team and to keep in mind that those families are going through the grieving process. And so some of the things that they may see that's coming across as distrust or being angry, they could actually be going through the stages of grieving. denial, anger, or even the bargaining stage. So it's important to kind of keep that in mind as well. So I think I will turn it over to Anna from there.
Thank you so much, Renita. So I'm going to speak to the ICU nursing perspective in a lot of these cases, and in particular, working with an interdisciplinary team. So as we've all kind of stated, there is an issue with building trust and rapport really quickly with these patients and their family members. And as a bedside nurse, you have a really unique opportunity and perspective in that you oftentimes will be the person who builds that rapport much faster than other disciplines. So one thing that I've noticed from my own personal experiences is that after a family meeting or discussion has taken place, being really aware of how that lands with the family. And if they need space, providing them with that space and circling back and having additional conversations. That has just been so crucial to providing them the care that they need. Like Renita was saying, ensuring that we understand their health literacy level, understand where they're coming from, and using language that is equivalent to ensure that they are actually being communicated with in a way that they fully understand the situation. And then once the family has had some time, checking in with them. You know, I feel like some of the most, some of the most intimate moments where I really fully understand what a family is going through is when I'm just in the room, like hanging an antibiotic and creating that safe space for them to confide in you. Because what I found is that as soon as the doctor leaves the room, there's no questions. As soon as they leave the room or after they've had time to process, that is when a whole litany of questions emerge. And oftentimes the issue with communication is the illusion that it has actually taken place. So creating that space to check it out with them. When we said as a medical team that this is what is so, how is that actually heard and interpreted by the family? And just taking time to be present. And I know it's not always easy and we don't always have time to do this, but to be present and understand their understanding of the scenario. Because what is most important and what us as medical professionals, our goal is always to provide the best care to that patient and their family. So once you kind of establish what is so, and a lot of it is also validating their fears and frustrations, I find it to be so crucial to take that information back to the medical team, include social work, make sure that we have all parties on board to fully understand where that family is, so then we can together create a pathway forward to best support them. So with that in mind, in speaking with utilizing all of our resources, I'm going to hand it over to John now to speak to a spiritual perspective.
Thank you, Anna. And I will be talking from a faith perspective, and these are the situations which pulls us in most difficult times of the family. And when we get involved, there are three different entities functioning towards the common goal. On one hand, here are the medical teams. On the other hand, the faith community. And the third entity is the family. Sometimes when we involve in this neurological declaration, there are things that kind of influence our professional influences or unconscious bias issues. My experience is that most of the time, the faith communities are a little skeptical as they kind of stuck with the loss and grief of the family, does not think beyond in sensing what is coming next or what would be anticipated as the next steps. From the medical team's perspective, they're highly informed both with medicine and science and the irreversible neurological injury, and bearing in the mind, they function from the utilitarian principle of ethics, what greater good would come after this. And that's never spoken out, but that is always influences in the declaration process because the timeframes are the crucial. And for family, which is dealing with this trauma, dealing with the secondary trauma of themselves, they're kind of lost and confused with the issues of induced coma, persistent vegetative state, or a faith leader coming to their bedside and saying that, oh, my pastor woke up so-and-so person, and a great aunt comes and says, oh, I have seen my sister coming out of this. And these are the situations we get involved. And as I stated earlier, the timeframes are the crucial. It is not that at what time or at what point we are engaging these examinations of the communication process, but it is important to assess as a faith leader where the family is. The language that you look for sometimes is that it is only possible to God to stop the inevitable. Then their belief and faith informs that what is not possible through nature or through science, it is only in the hands of God. So they turn that authority into the faith leader, asking you the direction and praying to God for grace and mercy. And sometimes you can also hear to the words that I would be glad to trade the places with my child. I wish it was me. So that was a clear sign of bargaining. And then, and at the same time, you also hear the words like, I don't know why God gave him to me, but he's trying to take him back. So they are moving from that phase of bargain to acceptance. And our role is to engage with these cases and helping them, as Renita rightly stated, the issues of race, culture, belief, faith, and assessing where they are, meeting them in those places and navigating from those situations. And sometimes it is appropriate to allow catharsis, acknowledge their experiences of loss and their feelings, and also sometimes the guilt and forgiveness issues and resentment, anxiety, panic, lonely, abandonment, anger, which may result in acting out in these kind of cases. So we have to deal with all of those and then helping them to accept the loss. And I'll stop there, and probably we will turn into Dr. Mark for.
Yeah, thank you all. So certainly welcome questions from the audience. If you could put those in the Q&A or in the chat. Maybe I'll ask the first one and try to incorporate a few of the comments from the panel. The idea of irreversibility, and then the skepticism by, in this case, BD's mother of, I'm praying for his recovery. I think he will get better. These signs that I'm seeing are a manifestation of he's still here and is going to get better. So how does the team navigate that? The idea of the irreversibility, 6 hours is enough to demonstrate irreversibility, but then a family that's still praying for recovery. Anybody want to comment about that challenge? Adam.
Sure. So I'll start with that. I mean, it's a very challenging, obviously challenging question, Mark. And one of the ways that we have to approach it is by just sticking to the tenets of what death by neurological criteria is and what the criteria are that we have to use to meet it. I mean, no matter what anyone says, death by neurological criteria is a legal construct, right? I mean, this is something that we as a society have come up with to say that we accept this as death, and which also means, of course, some people won't. So the way the irreversibility aspect of it comes into play is really from experience, and from my perspective anyway. And so part of the criteria for death by neurological criteria is that there has to be a reason for the exam that we're seeing. There has to be a reason that they're dead. And the primary way of accomplishing that is through brain imaging. And we know very clearly that certain types of injuries or global ischemia of the brain is not anything historically. I mean, we can't predict the future, obviously, but medicine always looks back for precedent, similar to the law in that regard, that anybody with a devastating injury like this has never woken back up, even in situations where it has been studied, where people have applied science to this. I think about Alan Schumann and Dr. Schumann's work with sustaining the bodies of brain dead people for extended periods of time. And even in that realm, there has never been a properly diagnosed case of brain death that has ever regained consciousness or survived. And so we can only base that idea of permanence based on what we know, both scientifically and through experience, but also through physical proof of the injuries that are actually there. And I don't know a way to go beyond that other than the interdisciplinary and multidisciplinary support from all aspects, social aspects of it, the medical aspects, the scientific, the humanistic, the palliative care aspects of it, and the spiritual side, as John was saying as well. All of these components of humanity have to come together and intersect and lock together in the right way for people to be able to move beyond that. And so the team effort on top of what we know really is the way that I can see being able to move forward with that idea of permanence.
I am something that you alluded to that I find really helpful is the power of images. So no imaging is required in brain death evaluation. As I mentioned, it's a clinical exam, but clinically, most often we're going to have something. And so in this case, we have both the CT scan and the cerebral perfusion scan. And I find with families, whether it's brain death or severe other severe brain injuries, that looking at the imaging themselves can be very powerful, and it kind of connects everything together. I always ask families if they want to see it, because sometimes the images are so shocking that I wouldn't want to impose that on anyone unwillingly, but they almost always say yes. And then with a brief explanation of what injured tissue looks like, they'll often then they get it. So we're looking at the entire brain. The really white part is injured, and they see the entire brain is bright white. Or in this situation with the cerebral perfusion scan, that scan is supportive of brain death if you see no blood flow in the skull. And so explaining to families, you need blood for your brain to recover, and there's no blood that is coming into this part of the skull. And looking at that image and seeing that there's nothing there can be very powerful, and I think can give them something more tangible to move forward with.
You're on mute, John.
One more thing I would like to add on to what Dr. Sharp and Dr. Shivey stated there. Sometimes making the family as partners in declaration and offering to witness the brain death testing, especially when there are no spinal cord reflexes. And in those case scenarios, it's very helpful. The family can be present, but it can be dubious if the patient has involuntary movement. In that scenario, we need to turn to the neurologist and triage, and that may help the family to enhance their trust levels. There is nothing shady here. Everything is transparent. They can hold their loved one's hand, especially in the children. Families will be breaking down to hold their loved child and be there. It means a lot to the family.
I've also found it helpful when they are able to bring in their own personal pastor or someone from their faith community that they already have a trusting relationship with. We had a case in the NCCU once where we had a family member's pastor come in who was a part of the brain death exam, who was a part of the family meeting, who was able to, the family trusted that person already. So, they were able to kind of relay to the family exactly what the physician said, but because it came from their pastor with whom they had a trusting relationship, it made it easier for them to kind of just come to the accepting stage.
I wonder if the is the other sign of evidence, the apnea test in particular is helpful for families, since since maybe some faith traditions rely on breath as a sign of life. Could anyone comment about how the apnea test works and whether that's been helpful for families? Go ahead, Adam.
Yeah, so I know that certain Orthodox Jewish faith communities think about life as through breath. I don't think I've personally experienced the apnea test specifically being the thing that led to acceptance or to repairing of a broken trust relationship per se, but just as a quick explanation of how the apnea test works, is we breathe based on our brain's interpretation of certain chemicals in the body, mainly carbon dioxide. And when the carbon dioxide levels rise, it stimulates the brain to tell the body to take a breath. And as you breathe, you get rid of carbon dioxide, and then it brings the levels in the blood back down. And if it gets too low, then the brain would not necessarily want to initiate a breath in that situation. And so what the apnea test does is, by providing enough oxygen for the body to continue functioning, allow for no ventilation to occur, such that the carbon dioxide levels would rise up high enough to be able to, I'm sorry, phone's ringing, to rise up high enough to stimulate the brain. In fact, we go even beyond that, like a higher than normal amount of carbon dioxide that would stimulate a healthy brain, because possibly a damaged brain would work differently. But we let that go up high enough such that in any situation, it would compel the brain to tell the body to take a breath. And if the apnea test demonstrates that the brain is not telling the body to take a breath in spite of these levels becoming very high, then that part of the brain is damaged beyond repair as well. And I think that a lot of the reason why breath is considered sort of this last vital sign of what life might be, at least from, it seems to be that way from a neurologic perspective. It is really the lowest part of the brain that is responsible for initiation of breath, because it is obviously such an important thing for all types of life and in all forms is respiration. And so all of the different tests that are being done are looking at different parts of the brain at different levels. And then the apnea test is sort of that very last bit that's saying, even down to the most, quote, primitive parts of the brain, there is no function there as well. And that, if explained properly, can be very helpful for patients. But just a quick explanation there too. I don't know if that is specifically was what you were looking for or not, Mark, but yeah.
Yeah, that's great. I will take a question from the audience, and Adam is certainly familiar with this case, but the audience member asks, how do you yourself deal with families who raise the case of Jahai McMath, a child who was declared dead on the basis of neurologic criteria by expert neurologist, was moved to New Jersey, kept on a ventilator at home. She went through puberty, developed movement to commands. Other neurologists also examined her and weighed in on the case. So if in particular families raise, well, Jahai McMath was declared dead, but she, her body kept on living. How do you deal with something like that?
Yeah, I can address it quickly, and I'm sure Dr. Sharp would want to weigh in on this as well. I bring up the idea of that the family had an objection, and this is technically a complication, as the way I call it, a complication, and that they were able to organize in such a way that they were able to get the patient to a location where it is legal to sustain a body. It's a little weird in this country, and I explain this, that you can be considered dead in California or considered dead in Maryland, but not necessarily in New Jersey if there's a objection to that form of death. Like I said before, it is a legal fiction, and so legality does play a role here. And if the laws in certain states say that we allow for citizens to not accept that legal fiction, that's okay. And so I I explain it like that, but then I also bring up the work of my friend Dr. Schumann, which I alluded to before, of that, you know what, it's not just Jahai. It's a whole number of people that have, and some people for longer than Jahai's case, that a whole number of people that have had their body sustained for a long period of time. But in fact, again, that is only in a situation for where it was allowed to do so, or it was legally appropriate or allowable. But in no cases ever has the status of the patient ever actually changed. The only thing that we witness is the continued failure of the body, which is inevitable, even in Jahai's case. It took a few years, but Dr. Schumann will tell you that it can go even longer than that. It's just a matter of how far do we want to wait, or how far would a patient's family want to wait as the inevitable failure of the body progresses. And when framed that way, I've found that people are able to understand a little bit more specifically to that type of objection.
I've actually, despite being in pediatrics, have not had a family bring those concerns forward. There's been some allusions to, well, are there ever, there's always a question, are there ever any kids who get better, or that if they are sustained long enough will have return of function? And then as Adam talked about, you know, we'll talk about the literature, we'll talk about our experience, but very often it's a fleeting attempt in one of those stages of grieving to say, well, what about this? Well, what about that? And I find that being consistent and being open to hearing those concerns and questions and taking patience and answering them, and sharing with them how hard it is for all of these details, even for the care team who are not experiencing anything like they are. Those are hard questions and to answer, and that this is what we understand, and this is our process, and this is what we do. And often those questions will be allayed, and they'll kind of move on in their grieving process, or to the next steps of the clinical process.
Anybody else? All right, well, I want to thank the panel. You know, obviously there are larger existential questions on, you know, what is personhood and what is the meaning of life, and, you know, all of the things that are wrapped up in a person's life and their family. And, you know, we're all trying to help the family cope with a very tragic situation. So I want to thank our panel, thank the audience for joining us today, and we'll look forward to seeing you next month for Ethics for Lunch. Thank you all.